Everybody. First of all, I would like to welcome the session chairs, panelists, and the audience to the Virtual International Scientific Conference 2020, organized by the Public Health Foundation Bangladesh. The theme of the conference is Response to COVID-19 Pandemic, Learnings from Home and Abroad. There are 7 scientific sessions in the conference, and the theme of the session is Health System. We have divided this session in 2 parts. The first part of this session will be chaired by Professor Syed Masood Ahmed, Director, Center of Excellence, Universal Health Coverage, Bragg James P. Grant, School of Public Health, Bragg University, and Professor Mahmoudur Rahman, former Director, IEDCR, and member of National Technical Advisory Committee on COVID-19 pandemic in Bangladesh. There are four presentations in the first part. The names of the presenters are Mr. Sheikh Rafi Ahmed, Mr. Vivek Poddar, Ms. Aisha Alam Pranti, and Ms. Aisha Kader. There are some instructions for the panelist. Dear panelist, you have to share your slides from your computer. But don't worry, if you face any difficulties, we will do it then. You will get 8 minutes maximum for your presentation. Dear audience, you can ask your question end of the presentation or end of the first part of the session by raising your hand using the respective option of Zoom. Moreover, you can write your question in the question and answer option of Zoom. And end of the first part of the session, we will request our session chairs to share their concluding remarks. However, now I would like to request Professor Syed Masood Ahmed sir to start the session and to continue first to presentation. Dear Masood Ahmed sir.
Dr. Masood, you are muted. Professor Masood, you are muted.
Sorry. Just I was saying that I was wishing good evening to you all and the very interesting presentations ahead of us. So the first 2 presentations are mainly on health system, on different aspects of health system. We have heard or we have observed many irregularities while responding to COVID, management of COVID and prevention activities. And the first one deals with the first-hand experience of one of the frontline categories of worker, that is the doctors itself, and how they managed, whatever the front lines that they experienced while managing COVID in their own capacities. And the second one is also important. At the early phase of the pandemic, we had heard some complaint about doctors not attending to duties. There was some quite, hue and cry. So we will listen from first hand also again from the doctors themselves, how from their perspective, how it was. So I will request the first presenter, please go ahead with your presentation. Thank you.
Hello, sir. Hello, Dr. Syed Masood Ahmed and Dr. Mahmoudur Rahman. Assalamu alaikum. Am I audible clearly?
Yes, you are. Yeah.
So I'm sharing the screen. Is the screen visible?
Yes, it is. It's okay.
Okay, so I'm going to start. Okay, so it's in full screen, right? Okay, thank you. I'm starting in 3, 2, 1. So welcome everyone. I'm Sheikh Rafi Ahmed on behalf of Economic Study Center and my team to present our paper titled Assessing the Fault Lines of Bangladesh's Healthcare Sector and Implications for Future Policy Response. So we're all students in our final years in economics. During the COVID-19 pandemic, we all decided that we're all suffering because of this pandemic. How about we actually try to find out the factors, the potential confounders that actually caused these problems, right? So over the years, we have experienced that Bangladesh has accomplished sustainable improvements. We have achieved MDG to a large extent. We have achieved reduction in maternal, neonatal, and under 5 death rates. We have achieved reduction in total fertility rate and increasing life expectancy, right? However, it still remains, our healthcare system still remains an extremely poorly functioning system because we have extremely high out-of-pocket expenditure. We have shortage of resources, resource misallocation. We have low quality service in public sector, and we have a lot of corruption and fund embezzlement. Given all of this, during the COVID-19 pandemic, all of this situation exacerbated and caused the suffering of millions of people in our country. So we decided that was particularly our motivation to conduct this study, that we want to provide a comprehensive picture of the state of our healthcare system and why it suffers so much in tackling a public health crisis like this. So we did this study this is basically a report from Economic Study Center. We did this in 3 stages. Firstly, we conducted a literature review on all existing literature prior to the COVID-19 pandemic. That is, we went through around 15 to 16 reports and a lot of other studies to actually conduct this literature review. The literature review itself was around 20 to 30 pages. And since we did not have enough data during the COVID-19 pandemic, because we are also preoccupied with the pandemic itself, we decided that how about we go through and conduct a study of our own. And we conducted 2 phenomenological studies. Since we're students from only 4th years, we are honor students, we did not have the resources to actually conduct a quantitative study. So we pursued 2 phenomenological studies, one for the doctors and one for the patients. So this is the first one, the literature review, a very brief overview of the literature review. Here we can see that poorer households spent as much as 5 to 10%, or in some cases way more than that, on their healthcare expenses, and if these households suffer from any form of health shocks, they would slide back to poverty according to World Bank. We've also seen that the overall cost of COVID-19 treatment became extremely high, especially after free testing was closed in June. We have seen that the physical and organizational infrastructure in our country is yet to meet safety standards for healthcare professionals like the doctors, the nurses, and in the hospitals. And in as recent as in 2019 and 20 fiscal year, we have seen that the government of Bangladesh allocated only 4.9% of the national budget to the Ministry of Health and Family Welfare, which is responsible for our healthcare system, right? So that's not good enough. Finally, we see that 75% of districts in Bangladesh have less than 50 isolation beds per 1 million people. That is a staggering feature, and that shows that how much scarcity of resources there are in our healthcare system. We also saw that there is an unregulated market of 70,000 unlicensed doctors, according to 2015 study by WHO, which might cause a potential opioid crisis like that of in USA. We of 4 different studies found that there is lack of accountability and transparency and a power of monopoly prevalent in our healthcare system. And there is another problem of too much centralization, that is the government controls almost all the entire budget of local bodies, and they believe that the Upajala Parishad are not disciplined enough to actually manage the resources themselves. In comparison to Vietnam, Cuba, and Kerala, we found that Bangladesh suffers, and Bangladesh is worse off in terms of A, healthcare expenditure, that is dollars per capita, and B, doctors per 1,000 patients. So the second stage, we conducted 2 phenomenological studies to actually find out on the field level. In the first one, we interviewed 7 doctors. The criteria of choosing these doctors were random. However, we maintained 2 particular criteria. 1, the doctors were currently employed in our healthcare system, and B, they actively treated COVID positive patients in some category or the other. So this was a huge process. We basically followed Collage's method, and we conducted the interviews over the phone after they provided consent. And once those interviews were recorded, and we transformed those interviews into verbatim transcripts. Later on, from these transcripts, we extracted 78 significant statements from these doctors, their lived experiences, not their opinion. Their opinion is irrelevant here, their experiences, how they suffered, how they were happy, and other things. And based on these 78 significant statements, we clustered them into 16 essential things for the doctors, according to the method of Collage provided in 1978. So these are the results. At first, the doctors expressed dissatisfaction with the mismanagement in terms of their medical education and scarcity of resources. However, they also expressed that they had a pleasant learning experience with the teachers. Despite the lack of resources, their teachers provided a lot of effort into their education. Thirdly, due to the lack of resources, they had to be innovative. One doctor said that she had to invent condom catheters to actually prevent the bleeding in a pregnant woman. Theme 4, they were extremely frustrated with this scarcity and inequality in terms of incentives during their early years, like during their internship, during their probationary periods. Theme 5, they were also afraid of security from patients. We have seen from time and time again that the doctors do get beaten up for very small reasons by the patients, and they do not have any form of security whatsoever. So they were very afraid of that particular scenario as well. They were also frustrated with the overload of patients compared to the sheer lack of manpower, that is nurses and cabin boys and others available, and doctors available as well. They faced corruption, which is very obvious. They faced difficulty in finding any time and funding for research, which is also an important factor here. They were frustrated with the health and administration being run by administrators who do not have medical experience or who have very little medical experience. They are frightened about treating the COVID-19 patients themselves because they were not provided with quality equipment, quality PPEs and masks. They were frustrated with the widespread misinformation, given that a lot of people came up with a lot of information like if you consume thankuni pata, probably you're going to get better off, and they had to navigate through all of this misinformation and treat patients. They were frustrated with the mismanagement of the health administration, especially during the COVID-19 pandemic. They suffered a lot because of the scarcity of testing facilities, and they believed that the testing facilities and all of those COVID patient treating centers required a lot of manpower. They were disheartened with the lack of ICU facilities since they saw that patients were dying without receiving treatment. And finally, most of the doctors themselves were infected with the COVID-19. So the last one was about the lived experience of patients. Here we took 4 patients and followed quite the similar methodology, except for the fact the patients had to suffer from severe situations that they had to actually get admitted to the hospitals, right? So these are the results of this finding. The patients experienced deficiencies and management of manpower. They had to wait a long time to see the doctors. They had to wait in long lines, and sometimes they were neglected by the healthcare professionals. They were neglected by nurses. They were neglected by the cabin boys, because the cabin boys, they felt that there weren't enough cabin boys or there weren't enough nurses going around. Patients were satisfied with private healthcare, although they felt that the cost was too much. This is pretty obvious. The patients also found that regular drugs in Bangladesh are quite affordable. The patients told us that they faced difficulty in finding seats in hospitals, especially during the COVID-19 pandemic. They were baffled by the widespread disinformation because it was very difficult for them. A lot of people were talking about a lot of different solutions. They did not know which one was correct. They faced difficulty with the testing process because there were long lines. It was either expensive in the private sector or in the public sector. There were long lines, which actually increased the risk of being infected by the COVID even more. Finally, the patients had an extremely painful experience of being infected. A lot of them said that they lost memories. They could not concentrate on their work. They suffered from muscle pain and they could not work properly, and a lot of other problems. They had to spend more for corona treatment compared to prior experience. They also found the public facilities in Bangladesh healthcare to be unhygienic but cost effective. And more importantly, they found that if they had political influence or connections, they could get seats or cabins in the hospitals easily. But if they did not have such political connections, it was extremely difficult to find seats, especially during the COVID-19 pandemic. They also had to pay more for essential amenities like PPEs, masks, and oxygen supplies during the COVID-19 pandemic. So basically, this was the findings from our research, from our study. We understand that since this is a phenomenological study and since we're students, there are a lot of limitations, but we wanted to pursue research in the public health sector. So we made this attempt. We welcome any comments, and this is a summary of our conclusion. Thank you, everyone. Thank you for listening to this presentation. Assalamu alaikum.
Thank you, Rafi Ahmed. It's a very nice perspective from both students as well as patients and doctors. Though the numbers are very small, but the broader picture is not very far from this. So it's good, and its research doesn't differentiate between students and professors and whatever veteran researchers. It depends upon how rigorously you have done the study, and that's more important. So I think you have done a good job. That's very good. I will now request our next speaker, Vivek Poddar, to present his study. Vivek Poddar, please.
Thank you, sir. Let me share my screen first. Is my screen visible?
Yes, it is visible. It's full screen. So just go ahead.
Good evening, everyone. This is Vivek Podar, and I am from Tyrone Memorial Medical College and Hospital, which is located in Ghazipur, Bangladesh. So today, I'm going to present a very important topic, which we worked for last, which we are working for last few months. That is willingness to work during initial lockdown period due to COVID-19 pandemic among the physicians of Bangladesh. And this study is very important to us because healthcare workers are the frontline professionals to respond during the critical time of pandemic, but they are confronted with uncertainty due to increased risk of contracting infection, physical and mental exhaustion, distress and complex trial decision, and grief of losing patients and colleagues during their day-to-day practices, and poor access to their personal protective equipment, and anxiety of infecting their family members. And we know that globally, over 90,000 healthcare workers have been infected with SARS-CoV-2 virus, and with increased mortality rate among than the general population. And in the face of uncertainty around this pandemic crisis, not everyone, not every physician can continue their work. Even though it is debatable, but still we hypothesize that their absenteeism will increase due to this pandemic situation. Their inability and reluctance of the healthcare workers to continue during this pandemic can put strain on the overburdened healthcare system like Bangladesh, which has a very low resource setting and very poor resources. So we feel that it is very important to determine the prevalence predictors and barriers of willingness of healthcare workers to work. The prevalence rate that
Sorry, I think there is some problem with the sound. I don't know. Raj TV, can you look into the matter, please? You can't hear.
স্যার বিবেক পদ্মার স্যারের ওইখান থেকে নয়েজটা আসতেছে।
Vivek Poddar, you are audible, but there is some howling noise from your device, maybe.
I'm using my laptop, so I'm not.
Now it's okay. Now it's okay.
Okay, thank you. So it is very important.
স্যার এখন আবার নয়েজটা হচ্ছে। আপনার প্রয়োজনে হেডফোন ইউজ করেন, হেডফোন ইউজ করেন।
Is it audible now?
Loud and clear. Yeah, it seems okay. Please continue.
So it was important to determine the prevalence predictors and barriers of willingness among the healthcare workers during this pandemic period, so that we can take some actionable plans to remove those barriers. So in our study, we investigated the prevalence and associated factors which we have already described during this COVID pandemic period among the Bangladeshi physicians, who are the major part of the healthcare workforce in Bangladesh. Our study design was a cross-sectional study, and it was done between April and May 2020. And the study participants were Bangladeshi physicians, and the data collection was online structured questionnaire which had 3 parts: social, demographic, and professional information, knowledge, attitude, and practice of using who recommended PPE, willingness to work during this pandemic. And we also used binary logistic regression model to detect the predictors of willingness of the physicians in Bangladesh. We found the majority of over 2/3 of the participants were between 21 to 30 years of age, and rest of them were over 30 years. And majority of the participants were female, which is 55%, and 45% were male. In our study, if we analyze as per the professional category, about 67% of the participants were early career physicians, and rest of them were either consultant, internal physician, or other healthcare workers, which we didn't take into account. And the most important part of our study, the willingness to work during this pandemic. And about 69, surprisingly, about 69.7% of the participants were willing to work during this pandemic period. And there are almost only 8.9% of the participants were not willing to participate. And 21.4% of the participants were not sure whether they should work during this pandemic or not. And most importantly, the predictors of willingness to work during this pandemic were the younger age, the experience of treating patients during the previous pandemics, the positive attitude towards their using PPE, high self-reported compliance to PPE, low self-perceived risk of being infected from workplace. These were the predictors which influenced their willingness to work during this pandemic. And there are certain barriers which also influence their willingness to work during this pandemic, such as their comorbidity, their fear of self-infection, their family concern of being infected, or whether they are pregnant or lactated women, or their lack of safety measures, and lack of proper working environment, and lack of adequate training, or maybe not practicing medicine. However, comorbidity, family concern, and lack of adequate safety measures were the major barriers to their participation. However, our study, despite of all these findings, we do have some limitations. Before concluding on that, I want to describe some of those limitations, because we have taken only the physicians, but our healthcare workforce is not only formed by the physicians. There are other healthcare workers also, which we didn't study on. The sample size was also small, and the survey was conducted online in social media. So maybe those physicians who are not available or not using social media may have been excluded. Also, the physical ability, the financial status, and contextual factors relevant to the willingness of the physicians were not explored, which could have given this different scenario in our study. In conclusion, I want to say the majority of the Bangladeshi physicians were willing to work during the initial lockdown period in this pandemic. However, there are some important barriers. Actually, as I have already mentioned, like the barriers were increased transmission of risk among the families, lack of personal protective equipment, and their negative attitude toward PPE effectiveness, and high perceived risk of getting corona infection. And so it is recommended that we need to ensure the adequate supply of personal protective equipment, and we need to support and recommend quarantine and isolation policies after risky hospital duty. Even though it may have been changed currently, but we are talking in terms of our findings from the initial lockdown period. And we also need to provide adequate and effective training to the physicians, so that they can protect themselves and their communities. Also, we need to take measures so that the barriers which were influencing their willingness could be addressed and resolved, so that they can continue their sacred duty during this pandemic period. Thank you.
Thank you, Vivek. It's a very nice presentation on a very sensitive issue. In the beginning of the pandemic, we had quite a hue and cry on this issue. And From our James P. Grant School of Public Health, we also did a study on personal protection and safety of the healthcare providers on a geographically representative sample of Bangladesh, including all types of healthcare providers, doctors, nurses, technicians, even ayas, cleaners, ward boys. So it is very important. And I must say that as a student, you have done a nice work. And I think there is a potential. I don't know how big is your data or how extensive, whether you have shown all the data. But you have a potential here to develop it into a manuscript, and yeah, I think it can be turned into a manuscript if you have sufficient other background data also. Thank you for your presentation. I think with this, we coming at the end of this two presentation, and I will then hand over to Professor Mahmudul Rahman to move forward with the rest two presentation. Professor Mahmudul Rahman.
Thank you, Professor Said Masood Ahmed. I welcome everybody in this session for the last two presentations. I thank the organizer also for inviting me to chair this session. And also I welcome all the participants who are here as a panelist and also attending this seminar. So as you have heard, that there will be two presentations. One will be from Aisha Alam Pranthi. She's an MPA student, North South University, and she will be making presentation of the healthcare seeking behavior of people with comorbidities during COVID-19 situation in Dhaka city. And as you know that this pandemic period, I would also pass a comment that people who have thought about doing some studies during the initial part of the pandemic, I very much appreciate those actually initiative and the reason for which we will be able to get some information what happened in the initial part. But maybe this would require more actually investigation to find out who has done what and bring those together so that we can understand much better. And which is, I would like to say that this is like, we say that this is lessons learned during the pandemic, which is sometimes we say after some sort of outbreak, we do an after action review. So this is something like an intra-action review, I should say, because it is already we are in the pandemic. And so that's the reason actually this everything will be helpful for us. Even this will help us to make some decision in the future. I won't take much time here because we will have to have some time for question and answer. So the presentation will be, as I said, by Aisha Alam Pranthi. So may I invite Dr. Aisha to come make her presentation and to upload the presentation. Over.
Assalamualaikum, sir. Good evening. I would like to thank Professor Mahmudul Rahman, sir, for giving me the opportunity to present my presentation. With the request and with the permission of my professors, I'm starting my presentation. Sir, is it audible and can you see me?
We can see you, we can hear you, but you have to upload your presentation. That's all.
Yeah. Okay, sir.
There is a noise, I think.
Yeah, I think this is the problem is there. Yes, Asha, we can see these slides. Go ahead, please. Asha, you are muted probably. Can you unmute yourself?
Yes, sir. Sir, can you hear me now?
We can hear you, but the slides are not there.
Okay, sir. So maybe there's some technical difficulty. I'm sharing the slides again. Yes, sir. Okay. Sir, this is our research proposal that we developed on, and it is on healthcare seeking behavior of people with comorbidities during COVID-19 situation in Dhaka city. And we would like to thank our honorable mentor, Professor Dr. N.D. Kapil Ahmed, sir. And the authors here are Dr. Veda Meher Manna, Dr. Tariful Islam, Dr. Mehdi Hassan, me, Dr. Aisha Muntanti, Dr. M.D. Redwan Islam, and Dr. Kaji Tamara Binte Kamal. So let's proceed to the presentation, and we would like to again thank Public Health Foundation Bangladesh for giving us the opportunity here. The background of the presentation: the novel coronavirus 2019, which first appeared in China in December 2019, and it has now become a threat in Bangladesh. And to inhibit the spread of the virus, the lockdown and the social distancing practices were implemented. And in uncertain times like these, vulnerable populations in a populous country, and especially in Dhaka city, may be further marginalized by inadequate health communication, proper healthcare, and online perform of medical services. So in our proposal, a community-based cross-sectional study over 3 months period from registered medical college hospitals targeting adult ages 40 to 60 years suffering from comorbid conditions can be conducted in Dhaka city to identify the age, sex, knowledge, and attitudes of COVID-19 among the respondents and their confidence in healthcare system and necessity through the telemedicine and some other pre-tested structured questionnaire, which will conduct via telephone call interview. In the study aims to describe the healthcare seeking behavior of the people with comorbidities. Those are in a big trouble during the COVID-19 situation in Dhaka city. The general objective of the study is to describe the healthcare seeking behavior of people with comorbidities, and the specific objectives are to identify the pattern of age, sex, educational status, household income, and occupational status in healthcare seeking behavior, to investigate the association between nutritional status and healthcare seeking behavior in people with comorbidities, to examine the knowledge and attitudes of COVID-19 among the healthcare seeking people with comorbidities. And we have done a literature review. Here it is. Initial essay of Marina Sherper et al. In 2020 conducted a study in USA about the attitudes and actions related to COVID-19 among adults with chronic conditions. But they suggested that greater public health efforts may be needed to mobilize the most vulnerable communities. But unfortunately, this study was done only in one city of US. Study conducted by Dr. Jolin Young et al. In 2003 in Hong Kong on health-seeking behaviors during SARS epidemic concluded increased practice of more favorable health-seeking behaviors. So there's also selection bias, which was seen in the study. The research question here is whether healthcare seeking behavior among people with comorbidities altering COVID-19 situation or not. Do comorbid people find an alternate way to ensure routine checkup? How often do they seek medical care during this COVID-19 situation? The research hypothesis here is in COVID-19 situation, people with comorbidities are unable to go to health facilities like hospitals or doctor chambers for routine checkup, but some of them seek help when necessary through alternate ways. So in the research methodology, we use the cross-sectional study here, and we will use a quantitative approach. The population and the sample, let's talk about that. Randomly, 2 medical college hospitals from all the registered medical college hospitals in Dhaka city will be selected. A complete list of the patients with comorbidities from them database will be formulated. Patients those do not have any contact numbers or addresses will be excluded from the list. After that, the respondent will be selected for the list proportionately to provide statistically reliable estimates. Let's proceed to the calculation of the sample. We have, of course, used the formula, and we will choose 400 as a sample size for convenience. The sampling technique is probability sampling here, and data collection instrument. Of course, there will be a pre-tested structure questionnaire, which will conduct by telephone call interview for our participants. Validity and reliability. The questionnaire will be tested to ensure its validity and reliability. And the data collection procedure, let's talk about this. There will employ the cumulative illness rating scale, which is CIRS, which will help us in analyzing the severity of the disease conditions along with multimorbidity cases. The questionnaire will be structured based on expert opinions of physicians and also by epidemiologists. Ethical consideration. Ethical consideration will be taken from both institutional, DMRC, and individual participant level. Data analysis plan. Data will be analyzed using statistical software, SPSS. Appropriate statistical method will be used for both bivariate and multivariate analysis. and plan to disseminate the findings. Study result will be presented in front of the government officials and all the key personnel by organizing a seminar. So we have presented a Gantt chart showing all the budget that we will need for over 3 months for this study period. And this is our proposal. And we would like to thank our honorable guests and our professors and our participants here for today for your patience hearing. And we would also like to thank our mentor, Dr. Kapil sir, for his support and contribution. Thank you so much. Assalamu alaikum.
Thank you, Dr. Asha. Yeah, I think this is a very, I should say that good move actually to bring up the presentation, this methodology and get advice from here so that you can improve your methodology. That will help you a lot. And I would say that this is a very, I don't want to use the clever word, as a good move actually, I should say for this. It was a good presentation. Thank you for the presentation bring up, but there are some things which need improvement. We will discuss this when the time comes. So let us
thank you, sir.
Last presentation, and we will allow time. Please, everybody, please write down your questions so that you can bring it up when we open it up for discussion. So at this stage, I would request, I should say that this was a coincidence, by chance, lot of friends. This is another Aisha Khader, and we got some background information from her. She is a Bangladeshi, but she came from Sri Lanka. She is the assistant professor, Department of Cardiology, Ibrahim Cardiac Hospital and Research Institute, Dhaka. And she will be making presentation on the impact of the COVID-19 pandemic on cardiology services at a tertiary cardiac center in Bangladesh, comparison over a 10-month period. I think we are eagerly waiting to see the findings from the presentation. Dr. Aisha, the floor is yours. Over to you.
Thank you very much, Professor Mahmoud Rahman, and good evening, everyone. And thank you to the Public Health Foundation of Bangladesh for the opportunity to present our research. It's titled The Impact of COVID-19 Pandemic on Cardiology Services at a Tertiary Cardiac Center in Bangladesh, where we compared all data over a 10-month period. So the background is, of course, that the COVID-19 pandemic has impacted not just cardiology, but all healthcare services across the globe, resulting in what is anecdotally we heard at the beginning of the pandemic in reduced numbers of patients presenting with and undergoing procedures, which we also observed for cardiac conditions. So the center I work at, Ibrahim Cardiac Hospital, is a tertiary cardiac care center in the capital city of Dhaka with structured inpatient as well as outpatient services and subspecialties of cardiology. Our outpatient services include ECG, echocardiography, exercise stress tests, ambulatory ECG, that is Holter monitoring, as well as tilt table tests. And inpatient services include all of the above, admissions, as well as additionally coronary intervention and pacing procedures. And to the best of our knowledge, there have not been any studies in Bangladesh specifically looking at the changes in patient and procedure volumes in cardiology services in relation to COVID-19 pandemic. So the objectives of this rather basic analysis, I would say, is to assess the impact of the COVID-19 pandemic on the following inpatient and outpatient cardiology services, that is emergency room, ER visits, outpatient visits, inpatient procedures, and outpatient procedures. And the comparisons were made between numbers of the corresponding months between 2020 and 2019. So this was an observational study. Institutional Review Board approval was obtained for analysis of this data set. And data on ER visits, specific inpatient and outpatient procedures I mentioned before were done, and they were collected via hospital electronic health records, echocardiography, and cath lab database. Data from January to October 2020 were compared with the monthly corresponding data for the same months in 2019 to observe for a percentage difference from the baseline being the numbers of procedures or respective visits for 2019. And a basic statistical analysis was done. This is the main result. We can see that the total number of outpatient visits from 1st January to 31st October 2020 was 17,606, which is a 36.2% reduction from the same period in 2019. And if we look at the monthly comparisons of the visits, we can see that outpatient visits in February 2020 was actually higher than last year. But with the onset of the pandemic, with the first cases in Dhaka at the beginning of March and with the lockdown, there was a gradual reduction in March, followed to a very steep reduction to less than 500 patients in the OPD in April 2020. We had 227 patients then. It persisted throughout May, and with the uplifting of the lockdown, we saw a gradual increase, and we have now picked up to a plateau with approximately a 20% deficit between the equal numbers for last year. In terms of ER visits, also there was a steep reduction in April, but unlike OPD visits where we saw a pickup in the number of patients presenting, emergency room visits remained very low, with the last analysis at the end of October showing almost a 60% reduction in comparison to ER visits in 2019. When we looked at the different outpatient investigations, these are the ECGs, concomitant with the reduction in the outpatient numbers, visits, as well as ER visits, there was a reduction in ECG visits, which was also again highest in April with a gradual rise, and it has almost picked up in October. Exercise stress tests showed a similar reduction in April, and it is gradually picking up with a 20% deficit currently. In terms of echocardiography, adult transthoracic echo showed a steep reduction in April, but we have gradually picked up. And institutionally, we have also instituted a practice where the operator, or rather the imager, is not in direct contact with the patient. So we have a physical barrier that would prevent the direct contact, which was one of the main reasons that precluded the numbers of transthoracic echo which were done. However, in terms of transesophageal echo, you can see that throughout April, May, June, and July, we had 0 transesophageal echoes done. This is because TE is an aerosol generating procedure. It involves intubation of the patient and a subsequent risk for the healthcare worker. This was at a time where we did not have enough PPE and we did not have enough N95 in the entire country. So consequent to that, there was a reduction. There was almost 0 TE procedures. Also, TE is not generally an emergent procedure. It is elective to decide on a long-term management in the vast majority of cases, which is why we did not see an urgency to perform this procedure. When we looked at ambulatory ECG, which is Holter, there also it involves having a device in the patient in skin contact, which is why there was again a reduction in April, but it has gradually picked up where we have been able to test patients, and if they're negative, we can give them this device which involves skin contact. Pediatric echocardiography also had very negligible cases throughout the period of April and May, and it has gradually picked up. In terms of cath lab, which is we are a very high volume radial center performing a large number of cases every year, we can see that there was a steep reduction in 2020. And if we look at it from March down to April, there was a significant reduction in the number of cases, which persisted throughout May to June and gradually increased in October. In terms of the procedures done in the cath lab, coronary angiograms showed a reduction, but gradually we picked up because at this point, somewhere around July to August, we developed in-hospital on-site SARS-CoV-2 RT-PCR services where we could test the patients once they were negative and take them to the cath lab. So we have considerably picked up in terms of coronary angiographies as well as PCIs. We can see that the numbers are not as drastically a big drop as in the outpatient investigations. So this is the tabular data of what I just presented. The largest reduction we saw was in April, of almost a 92% reduction in outpatient visits, as well as procedures, and approximately 78% reduction in emergency room, which has of course persisted throughout right up to the last date we analyzed. So this is not normal for only Bangladesh. All over the world, in the UK, Singapore, Hong Kong, Italy, they have shown reductions in cath lab volumes, reductions in ACS presentations, reductions in cardiac investigations. But we also have problems that are of our own. So in conclusion, I'd like to say that there was a significant reduction of both OPD as well as inpatient services, especially in April and May, coinciding with national lockdown measures. In Bangladesh, however, this reduction we would postulate is probably explained by patients being unable to reach hospitals from the periphery, because the services we offer are not all available in the periphery. And once the lockdown was lifted, we did see an increase in the number of procedures, particularly in the cath lab. And of course, patients themselves deliberately staying away for fear of contracting COVID-19. Outpatient and cath lab services gradually picked up following the availability of RT-PCR of SARS-CoV-2 on site. And currently, trends show a steady increase in services beginning from July, but they have not yet reached pre-COVID volumes. So the recommendations going forward is, of course, this study had limitations. This was entirely observational, and in the absence of detailed electronic health records, our analysis was rather limited. We could not go into a more detailed analysis in terms of mortality because this was retrospective. But going forward, the recommendations are, of course, that this is a new normal that we need to learn to live with. On-site SARS-CoV-2 RT-PCR and availability of ancillary tests can help streamline logistics and tests according to appropriate indications. This is something that we found very helpful when we decided to perform investigations on patients, because the healthcare worker was given the assurance that this patient was negative, so there was no risk in performing certain procedures. In terms of hospital premises, we have now a separate red, amber, and yellow zone to ensure that there is no mixing of positive and negative cases and transmission between patients as well as to the healthcare workers. Improve logistics in terms of the physical barriers I mentioned for echo to prevent patient contact during procedures. And of course, very importantly, we now have adequate and appropriate PPE for protection of the healthcare workforce, which facilitates giving better services to the public. And last but not least, there is an importance of public health messaging to tell people that cardiac emergencies are certainly not elective. They need to be tackled urgently, and they need to be presenting to the emergency room in case of such emergencies. So thank you for your attention, and thank you once again for the opportunity to present.
Thank you, Dr. Aisha, for the nice presentation you have brought up. Though this is supposed to happen during pandemic, it is the usual picture. Let me say what happened today, this morning in the BBC, in the radio, it was mentioned that the transport system of some countries like USA and UK, this is in really bad shape and they are going out of business. So there was a question that how much time it will take to come back to the normal. And it was mentioned that it will take a lot of years to come back to the normal because people will go for new normal and they will come up with some alternative methods. They're working from home. And this is also like when you say that people are not coming to the hospital. Some of them are actually waiting. Some of them are taking advice over the telemedicine, which has become so common now. People are also taking advice from there. And at the initial stage, as you have rightly mentioned, that there are a lot of hurdles, actually, people were, we officially don't say lockdown, but it is actually, I mean, that movement was restricted at that time. So for that reason, people were not been able to come to the hospitals. At the same time, hospitals were also not treating the patients because without a negative report and all these things. And there are a lot of barriers. So it is a multiple factors which didn't allow patients to come in taking the service. But as you said, cardiac patients are really emergency patients sometimes. So they need actually some sort of emergency treatment also. But really it was hampered and still now people. And even if you ask us, we delay, we are delaying that, okay, let's go do it, our testing or regular, even the routine testing which was being done for people who are at the age of more than 60 or some at level or having some comorbidities, they were having routine tests. Those are being also postponed for certain periods. So this is what has happened, but it's a good work you have done. I would say that you should continue this and also look into this, some of the causes, not on the basis of the secondary data, also having some interviews done who are coming now, what happened, what was their actually thought, so you can get a better perspective on that. I think it is 8:19, maybe Professor Masood, we can open the floor for discussion and asking for any question. If you agree on that, I hand over the microphone to you, but we can, it is open for asking question. You can raise your hand and then you can be allowed to speak. Over.
Dear audience, now the floor is open for question and answer.
Yes.
If you have any question, please ask to the respective presenter.
Yeah, Professor Aftab, please.
Nobody is actually eager to come up as a volunteer, so I'm just going to volunteer. Dr. Aisha Kadir. I think, yes, already Professor Mahmudur Rahman nicely put together all your experience and the nitty-gritty and the limitations also. I'm a bit curious. At some point, you have mentioned about the importance of electronic record, medical record. So can you just little bit elaborate for us what is the implications of this? Keeping this electronic medical record could improve these services, cardiac services.
Yes.
Please.
Yes, thank you, Dr. Aftab. I think it's not just cardiac, it's actually the healthcare services at large that can significantly benefit from having electronic records, because in countries where they have developed trends, particularly in the UK, where I'm in touch with somebody actually who has developed data in real time to identify predictors. I mentioned one of our limitations was that everything was observational and I couldn't find predictors of certain things. That's because I don't have the data and it was retrospective. I'm comparing it with 2019. But if there were an electronic health record database, which is large and with which we can do very large studies and extract a large amount of data, we can actually predict trends, because the population of Bangladesh is huge. So whatever data we present or we enter manually is like a drop in the ocean in terms of extrapolating it to the general public and making it generalizable, which is why I think if we can develop an electronic health record system, even maybe starting on a small scale and perhaps then pitch it to the state or the government to do it on a larger scale, I think we will significantly benefit. And that should be the idea of Digital Bangladesh.
Okay, thank you. Dr.
Badruddin. Thank you.
Thank you. Thank you, Professor Aftab, sir, for asking the question. And thank you, Dr. Aisha Kader. Your study is a wonderful one. In fact, I should thank everyone like Vivek Poddar, Aisha Alam, and Rafi. All young faces, young people did wonderful work. I mean, I'm surprised that our young generation is doing such good work in Bangladesh. Please keep it up. Nation needs you. In the future, you can contribute in the development of our nation. And in keeping with Dr. Aisha Kader's recommendations, yes, I believe it is time. It is time. Like we do have use of information technology everywhere, even in our daily life. So why not in healthcare? And we need to implement or introduce the electronic health record system, maybe starting from smaller scales, as Aisha Kader said, and then extending it to the national level. This is the need for the day now. And if we have that, many things will be so easy, like tracking the trends, tracking the risks, and predicting future changes and future needs. It will be possible. I believe I can see here in the panelist, Professor Tanvir Chaudhry Turin, who is a very renowned scientist in Calgary and Canada. I think he can throw some lights also if he wants in this regard through his expertise. Thank you very much.
But I think also Professor Mahmudur Rahman and
sir, your voice is
Masood, you are breaking.
You can also throw some light, because we know that you are having this in Bangladesh.
Yeah, I don't know whether Turin wants to say something. I see a lot of my students, and you will be surprised. Dr. Aftab, Dr. Professor Masood, they were all my students. So,
Assalamu alaikum to all.
Turin, please go ahead.
Yeah. Sir, the only thing I was just trying to say, like, I think it was definitely too much impressive, and then the works the people are trying to pull off. So a facilitation of those definitely will be great. And then, in the Western world, they're trying for this electronic medical records. Thank you for the question, Dr. Aftab, and other person who brought it up. So if we have a, I think if we have a way of surveilling it, and I think Professor Mahmoud Rahman knows the best about it, doing in a resource stress situation. Dr. Aftab, he will be also knowing great things about it because his work in ICDDRB and other places. So I think there is this extreme need. This COVID shows us this digital technology we need to use in our context, and that will, you know, previously we used to be a little bit afraid of doing research in our resource trap context because lots of things were heavily dependent on the resource. But that technology shows that we can use these resources for our own benefit, and it's there. It's a more of a part of life rather than anything special like before. That's just my small input among this big, all big. আমার জীবনের big অসৎ বৃক্ষ যারা আছেন তাদের আন্ডারে।
Thank you, Thurin. Nice to see you from such a long way. I think we have 4 minutes left, but I don't know. Masood might have some.
Can I compliment just one issue? From the first study, I just wanted to. Nobody brought about this one, but this was very important. Although the sample size is so limited, already Professor Masood mentioned about this. The two important aspects they have brought about. One is the medical education aspect. Another one is the healthcare aspect. So my view is that there's something that quality of medical education as well as quality of healthcare is actually goes hand by hand. And in our situation, what we see that medical education is almost divorced from the healthcare system. So that's the message I would like to actually emphasize here, that we need to actually draw the attention of the policy and decision makers. Some way we need to bridge together, marry together. Otherwise,
Thank you, Dr. Aftab. We are running out of time. So, Professor Masood, can you give your concluding remarks so that after you, I can also say a few words? Professor Masood?
Yeah, sure. Thank you. Just a few words that the COVID-19 response in Bangladesh has been characterized by poor coordination, lack of appropriate leadership and governance, corruption, and all these factors, ad hoc, fragmented, this kind of responses, not heeding to the opinions or to the, not taking proper use or not making proper use of expertise of the public health community of the country. So these we know by this time, and we are already 9 months into the pandemic, and not much has improved. So that's the fact of life. It has bared open the weaknesses of the health system like anything. We were knowing, the insiders we were knowing, but then it is now open before the country. So I think there is an opportunity to heed to these problems. The students that presented in the first 2 presentation was very excellent, and they have touched these very sensitive issues. And I think there are elements in here where public health policymakers can also pay attention to this. Yeah, I think that I also congratulate the students and the presenters.
I think
and also the organizers for it to happen. Thank you.
Thank you, Sir Masood Ahmed. Actually, I thank all the presenters. Actually, they did a wonderful presentation and they prepared very well. But there are always, no study is 100% correct. There will be some bias, and you have to reduce the bias as much as possible. So few things I would like to say on the not everything in details, like Vivek, when you have mentioned about the like social media, you have to take care of the situation that whether the doctors who are responding, whether they were the first line worker or not, whether so that something has to be understood, whether they are in the real field, so that the response which they give, whether they give the right one. Might be you have seen it, but I'm just flagging it up for you to take care also when you do it. Regarding the health-seeking behavior, I think actually, Aisha, you have to go to the people who have not come to the hospital also, because unless you go to there, you cannot understand the health-seeking behavior. Only people who are coming to the hospital, they are the critical patients, and I think you miss a large part of that. So even if you do something on those patients, you have to bring it in a way so that it reflects their situation. And also, I would like to bring in a very important issue is an ethical question. Ideally, you cannot have the information of the patients from the hospital. Hospital, on an ethical point, without the consent of the patient, cannot give the telephone number to you, even the address of the patients whom you want to contact after they have been discharged. So that is an issue you have to keep in mind. Though you have mentioned that you will have ethical clearance, but you as a researcher also will have to take care of that so that you don't encroach the privacy of the patients. And it might so happen that you might reach a patient who has passed away also, but we don't know that. So you have to be very careful about that. And Aisha Kader has also, I have commented some sort of continuation of these studies so that you can go in depth actually for understanding a little bit more on those people who are still coming, why they have not come. So you can have a, that face-to-face questioning and to get more in-depth understanding of the situation. I thank everybody again, and I would like to hand over the microphone to Ghulam Rabbani. We are 2 minutes over. It usually happens. We started also a little late. Thank you, everybody, and good evening. Yes, Dr. Ghulam Rabbani, please.
Thank you so much, sir. Thank you so much. I again would like to thanks to our honorable chair, Professor Soed Masood Ahmed sir and Professor Mahmudur Rahman sir for their insightful comments and discussion. Before ending the first part of this session, I would also like to thanks to all of our presenters for their excellent presentation, which might have significant contribution in policy making for our health system. I also like to thanks to our audience who is still with us from 7:30. Before ending the session, I would also like to thanks the organizing committee and all of the members and present members. Thank you so much. Successfully, we have just completed the first part of this session. Now we are going to start the second part of this session. The second part of this session will be chaired by Dr. Aftabuddin, Head, Technical Training Unit, ICDDRB, Dhaka, Bangladesh, and Dr. Taufik Jiwaddar, Executive Director, Public Health Foundation, Bangladesh. There are also 4 presenters in the second part. The name of the presenters are Ms. Fatima Yasmin, Mr. Turin Tanvir Chaudhuri, and Ms. Saeeder Rahman, and Mr. Badruddin Omar. Now I would like to request to Dr. Aftabuddin Ahmed sir to start the session and to continue first 2 presentations. Dear sir.
Thank you so much. I was looking for the presentation, titles. Anyway, I got it in my PowerPoint. I got only 3. Anyway, the rest one will be direct, I hope. So I'm now inviting for the first presenter, the effects of COVID-19. I could see this one. The effects of COVID-19 pandemic on health, economic, and social life. Dr. Farhana, or I don't know actually who will be presenting this one. I see here Farhana. Please, is it Dr. Farhana or someone else? Hello? Can you hear me? Who is going to present it? If not, I can invite another one without wasting our time.
Yes,
So,
sir.
and
You can ask the next one.
Also, is there anyone? Also, Dr. Taufik is there or not? I don't know. I couldn't see him. Anyway, I'm asking the second study for presentation. It's polypharmacy among the geriatric population during COVID-19. Why do we need to be concerned? So maybe Dr. Saida Rahman will be presenting, please.
Yeah.
Saida is there. Yeah, okay. You are welcome. Okay. So without any further introduction, just you can start your presentation.
Right.
Okay.
Okay.
Sure.
Okay.
Saida,
Can you, I have to share my slides first, I think. How to share the slides.
So can you share the slides? So you see at the bottom, the share screen. First, open your presentation, and
then I have done it. Yeah, I have done it. Okay. I've done it. So this is the one. Okay. Right.
Yes, please go on.
Yeah, can you? All right, okay. Assalamu alaikum and good evening, Honorable Chairperson and respected participants. I'm Saida Rahman on behalf of our team from Barbados, West Indies. And I'm going to talk about a very interesting topic related to a specific group of population during this COVID-19 and the polypharmacy among the geriatric population during COVID-19. Already we know about the COVID-19. That is a well-known fact that it is epidemic. This epidemic is originated in one province, China, and it has spread in more than 60 countries in the world. And it is also seen that it is well documented that the severity of the disease among the world population, and it is found that it has more severe among the elderly population, specifically due to their existing chronic diseases. And all these disease condition among this elderly population has provided a significant challenges to the healthcare professionals. Now we will have some, So with respect to this one, this effect of this COVID-19.
No voice, Dr. Aisha.
We cannot hear.
No voice, Aisha. No, Dr. Saida, no voice. No voice. Please take care. Aisha, we cannot hear you. Please recheck your audio. Check about this one. We cannot hear you.
Plug out your jack and plug in again. Maybe it will fix. Maybe something is loose.
Yeah. Can anyone from the technical side can help her? Hello?
আপনারা কোনো একজন কন্টিনিউ করেন, সাইদা রহমান কে আমি ফোন দিচ্ছি।
ওকে। Saida, can you hear us? Can you show us that you hear us? Okay. Maybe we can ask the next presenter, and then you fix your problem and come back, because we are losing time. We cannot manage. So thank you, Saida. Now I'm requesting the next presenter. Maybe it is Dr. Badruddin.
Sir,
I don't know the.
Sir, our first presenter is available now, so we can.
Okay. Please. Dr. Saida, you can just stop sharing. Or
our first presenter name is Farhana Yasmin, sir.
Manage that.
Abbo, sound বন্ধ করতে হবে।
Hello, assalamu alaikum.
Walaikum assalam.
Walaikum assalam.
Yeah, please.
Miss Farhana Yasmin, are you able to share your screen?
Is it Dr.
আমার স্লাইডটা আপনি একটু শেয়ার করেন আমার।
Okay.
Okay, you please go on. Please.
সরি আমার নেট কানেকশন খুবই খারাপ ছিল। Hello everyone, hope you are all well in this pandemic situation. I am Farhana Yasmin, a student of Sociology Department of Borishal University. My presentation topic is effects of COVID-19 pandemic on health, economic and social life. Before starting my presentation, the first thing I want to say is that actually my paper is on kind of ongoing paper. So now I am going to present to you an overview of my study on different slides. Let's see. Actually, we know that introductory part is the first part of the research work. Let's see. COVID-19 pandemic is now recognized as one of the most tempting challenge. It is the alarming tragedy of the century after Second World War. It is not a man-made virus. It is a respiratory disease.
I am paying. May I have the attention? Excuse me.
This disease began on late December 2019.
Rabbani, there is two presentations simultaneously going on.
Dr. Sharmeen, this is Professor Mahmudur Rahman. Which two presentations you are talking about? You are muted, please. where are the technical people?
Yes. Okay. There is a sound problem.
No. That's why I don't understand why there should be duplication. We asked the earlier presenter to stop screen sharing, right? So has she done it? I cannot actually assure now. So please check it.
There is only one presentation being shared on the screen. That's
Okay.
Dr. Farhana's. I don't think there is another presentation going on.
I don't know because I cannot check it. Now I see the only one presentation. Farhana is going on. Okay, please, Farhana.
We should let Farhana continue.
Yeah, please.
Thank you. Then the COVID-19 began on late December 2019 in Wuhan city of the Hubei province of China. The World Health Organization regarded it more powerful than a terrorist attack. Finally, on 11th February 2020, the World Health Organization renamed it COVID-19. However, the entire world population currently faces numerous challenges on health, economic, and social life due to the impact of COVID-19 pandemic. Let's see. Rationale of the study. This research work will be able to describe the situation of health, economy, and society during COVID-19 pandemic. Consequently, the findings of this study will be able to contribute to the knowledge of planners, policymakers, and administrators to check out an appropriate, meaningful, and realistic policy to cope up with the challenges issues of health, socio-economic system. Next slide. The first things that comes to our mind before conducting any research work is to determine the objective. That's why objective part is very important part of the research work. However, there are two major objective in this study. Number one, to explore how does COVID-19 pandemic affect our health, and another, to know the socio-economic condition during COVID-19 pandemic. Next slide. Methodology is very important part of the research work. Actually mixed method is used in this study. Mixed method is the combination between qualitative and quantitative method. Quantitative method includes survey questionnaire, and here also qualitative method includes 5 SGD, 5 case study. Here purposive sampling procedure is used and sample size is 15. Next, effects of COVID-19 pandemic. The whole world population currently faces enormous challenges due to COVID-19 impact of due to COVID-19. COVID-19 has affected day-to-day life. Now I'm giving some different ideas on health, economic, and social impacts of coronavirus outbreak. Next, impact on health during COVID-19. Corona is a virus. Hundreds of people are dying every day in the world due to this virus. Again, hundreds of people are being affected every day. Also, this pandemic is directly affecting our health service, like risks of health system breakdown. We know when dealing with any pandemic, the health system aims to prevent the spread of a particular disease. When the pandemic is widespread, everyone is busy dealing with disease. In doing so, in most cases, the process of providing many basic health service lost importance. As a result, many people are suffering. As an example of an Ebola outbreak, outbreak in West Africa, statistics show that more women have died than Ivalu due to lack of access to basic maternity care. Then risks of pregnancy women. Just as there is panic among the general public about coronavirus, pregnant women are those who are breastfeeding are particularly concerned. There is not much information about coronavirus so far. However, the immune system is weakened during pregnancy. So the risk of any flu or any other infection is higher during pregnancy. So if you have any kind of cough or fever at this time, it will be possible to avoid the next risks if you seek the help of a doctor at the beginning. Risks of fetuses, very limited research has been done COVID-19 yet. However, influenza or other types of coronavirus infections can lead to miscarriage, impaired baby growth, premature birth, birth defects, or loss of the fetus during high temperature or fever, or even death. If you have any type of cough, fever, it is possible to avoid the next risk if you seek medical help at the beginning. South Asian have the highest risk of dying. A survey conducted in Britain found that people of South Asian descent are more likely to die from coronavirus infections, and one of the cases in diabetes. This is the largest survey of the world's response to COVID-19 infection in different ethnic groups. Mental illness of all ages of people of all ages, including children, young and old, are under a lot of stress due to coronavirus. Everyone is under house arrest because of the lockdown. Not everyone remembers in peace of mind. There is no vaccine on it. All the world's great scientists are trying to discover its vaccine, but when the vaccine will be in everyone's hand is still unknown. Due to the lockdown, most people have lost their source of income. How will their family survive in this situation? What will they eat? Or what to wear? People all over the world are living in such 1,000 worries. For example, if a driver is unable to drive due to a lockdown period, how will be able to support his family? They will die without eating because they are stopped in lockdown to escape from corona. Next slide. Impact on society during COVID-19. World Health Organization announced coronavirus, which is also referred as COVID-19. It is also social phenomena which impacts the society of the individual as a whole, like raising global poverty, lack of special care of disabled children. Children with disabilities are being deprived of their special care due to coronavirus. Because of this disaster, they are not able to sit freely under the open sky. They are confined in the same room as the bird in the cage. As a result, their mental growth is disrupted. Raising forced marriage at a time when the COVID-19 pandemic has forced the world indoors. Child marriage seems to have risen in the country due to the current pandemic situation. All schools are closed for a long time. This acts as a major driving force of the child marriage. Mental hamper of students during COVID-19. Lockdown, shutdown, quarantine, and social distance rules are enforced in all countries. School has been closed for a long time. The psychological and mental hamper among the students has stronger. Inferior attitude towards women during COVID-19. In this pandemic situation, women are being neglected in many ways, or working women are under more pressure. I saw another thing in the rural society are unable to go to the market regularly during Corona. And so many people are saying that it is good because of Corona. that girls and women are not able to go to the market. The market's environment is cold and quiet. It seems to me that girls and women are being neglected. That means inferior attitude towards women. Raising women violence. It is now common knowledge that a pandemic or any emergencies for that matters impacts women and girls differently than men. While the direct health and financial risks are common for all, it is the additional risks of facing violence and discrimination at home and outside that women and girls have put up with during any emergency.
Hello, Farhana, you have to go fast because your allotted time is, so you have to go fast. This is not the time for detailing. Please, ensure you as early as possible. Yeah, please.
Yes. Not getting proper socialization during COVID-19. In this pandemic situation, the children are being deprived of their proper socialization. I think the children of a policeman or doctor are away from their parents when they come back from their duty. As a result, the children are not getting proper socialization, which disturb their mental growth. Next. Last one, everyone needs to be humane and aware to survive from corona. Moreover, everyone should maintain a helpful mentality. We must be practiced to wear masks regularly for expecting a bright sunshine again, and must be believed on no masks, no service slogan. Thank you, everyone.
Okay, so may I now request Dr. Saida Rahman? Are you there? Hello, Saida? No. So I think that we can go for the next presentation, which is a survey on the impact of professional training on physicians' perspective of COVID-19. I see here Dr. Badruddin Umar here. So may I ask Dr. Badruddin Umar to present and share with us. Nice. So please go ahead.
Good morning from Toronto. Thank you, Aftab sir, and the panelists and the audience. Good morning from Toronto. It's a chilly and a snowy morning here, but I believe it's pretty warmer in Bangladesh. Anyway, thank you for giving me the opportunity to present here today. Is my slide shared? Can you see it? Hello?
Please go on.
Okay, thank you very much. So I am presenting our research paper, which is a survey on the impact of professional training on physicians' perspective of COVID-19. And these are our team members. We are 5 doctors from Bangladesh. We work in different countries. Most of us are in Canada. So going to background, we can see that COVID-19 disease is associated with significant mortality and morbidity, and especially mortality among healthcare workers plus doctors globally. And most of the countries in the initial days, like the beginning of this year, was not prepared for facing this situation, and there were lack of proper guidelines and established measures in many countries, even the Western countries. So COVID-19 was declared as a global concern, global pandemic by WHO, and only thing we have till now is the taking drastic measures to stop it or slow it down. And it was found from several other studies, previous studies, that knowledge, attitude, and practice of COVID-19 diseases affects people's behavior. And it was also revealed from previous works that there is a knowledge gap in the healthcare workers, which leads to improper practices. There are many training modalities available in different formats, online, live, and so many different ways. But the reports on their effectiveness is very little. Physicians, being the leaders in the healthcare team, has to take the largest responsibility and face the challenge. And they should be extensively ready to lead the team and prevent and manage the COVID-19 infection effectively. So the aim and objective of our study was to assess or find the effectiveness of the training modalities available online or otherwise on the physicians towards enhancing their knowledge, ensuring safe practices, and improving behavior on COVID-19. So we conducted a descriptive cross-sectional online survey using a pre-tested questionnaire through online platforms. The questionnaire or the survey tool had 31 items, and these were based on WHO guidelines, previously used survey tools, and web-based materials. 161 doctors from around the globe participated in this survey. So we studied the characteristics, especially the demographic and other characteristics of the physicians. And then we surveyed about the awareness of COVID-19, information sources, plus knowledge, behavior, and practices related to COVID-19 among the respondents. The survey instrument was sent, a link was created and sent to the participant through Google form, and we followed the prescribed guidelines for checking the consistency, clarity, relevance, and approximate time needed to complete the survey. And those were not included in the real analysis. Data was analyzed, used SPSS version 24. We did mainly the descriptive statistics, but we also did few other statistics. So the main results. A total of 161 physicians participate from 15 countries of the world. Most of the respondents, over 70%, received some sort of training during this period. And these trainings were either from the workplaces, which is 60%, or from the international agencies like WHO, CDC, and others. And these trainings were either in-person trainings or online trainings. 43% of the respondents or responding doctors had advanced knowledge scores, and 40% had competent knowledge scores. So that is pretty much good. And improving knowledge progression was displayed by the cohort who received professional training. Duration and source of training has impacted the knowledge pattern positively. The training modules also affected the behavior and practice positively. So that's a good finding. We can see some tabulated form. So we can see it's actually predominantly male doctors who responded. I don't know why females were responding less. And the age distribution, if you see, you will be surprised to see that like pretty younger group and little bit middle age group of respondents participated more. And that's another interesting finding. Most of the respondents were from the lower middle income countries like Bangladesh, India, Pakistan, and others. If we consider the practice setting, 138 out of 161 was actively in practice, the doctors. And 39% work in the outpatient settings, 33% in the inpatient settings. And 58 of them were directly in contact with COVID-19 patients. That means they were involved in providing care to those patients. And unfortunately, 16% of these doctors got affected by COVID themselves. And this chart shows the trend of knowledge score in relation to professional training. So you can see that with the training receiving, the knowledge scores is steadily going up. Yeah, there is a little bit drop here at 0.6, but there is a persistent rise thereafter. But on the other hand, you see people not receiving training or doctors not receiving training, there is a downward training.
Dear Umar sir, you have 2 minutes more.
Yeah, I'm almost done. Thank you very much for reminding. So our conclusion. Professional training is effective in enhancing knowledge, improving behavior, and ensuring safe practices among physicians. So training modules for physicians and other healthcare workers are warranted to tackle pandemics or pandemic-like situations. So thank you very much, and we welcome questions.
Okay, thank you, Dr. Badruddin Umar. Excellent presentation.
Welcome.
We will come up for discussion later on. So may I ask the rest participant, maybe Dr. Saida is there?
Yeah, I'm there.
Okay, please you continue, but you keep reminding the time is very limited. And
yeah, I can understand that.
I have to leave the session by 9:30 sharp.
Right.
I have another session. Yeah, please.
Okay. Can you hear me clearly, and can you see the slides?
Yeah, please. You go on quickly. I think just a minute. Ghulam Rabbani. So do we have any other study?
Yes, sir. We have another study. Dr. Turin will present.
So then how much time she'll get? Because I can stay only around 9:30. In between, we have to finish it. Yeah, please. Please, okay, Dr. Saida, you go on.
Okay. So should I start it from the beginning, or should I go from the?
8 minutes for you. Okay, thank you.
Okay, should I start from the beginning, or that? So I'm starting from the beginning, actually. That is, we are talking about, and thanks for giving me this opportunity, first of all, because it is interrupted during the presentation when I started first.
Please go on directly. You go on.
Okay. All right. Okay. Yeah. Okay. Thank you very much, sir. So this is, we are talking about the polypharmacy among the geriatric population during the COVID-19 condition. And already my previous presenters, they have talked a lot about the condition of the COVID, where from it is generated. So I'm not going to discuss those things as far. But in this data, it is showing that the severity of the COVID in worldwide population, and it is so seen that it is mostly affecting a lot to the geriatric population. And it is one of the reasons that is concerned with this geriatric population due to their chronic disease state, and so also the use of lots of medication due to their comorbid condition. And this thing is related to here about the polypharmacy with this respect. And if we define it in a very simpler way, that is, it is multiple medication used by by individual person, and when there is number of medication is 5 or more than that in a simultaneous condition. And polypharmacy is actually more imperative in the elderly population, and it is found to be a growing concern because of different drugs not only increase the expenses, but also it causing the harmful effect to the patients. And in the pandemic condition, polypharmacy has emerged a public health problem, and it is a growing concern to the elderly population worldwide. Let us see some examples here. This is a study which has been conducted. It is a retrospective cohort study conducted in UK within GP practice, and they have shown that 77% of the population having age from up to 75, they are and so also when the age is more increasing, the 44% of them, they are having more comorbid condition. And as a result, it is so seen that the number of medications they're using is near about 6 to 8 prescription medication in a day. That next example is similar type of study that had been conducted in Abu Dhabi. And they have also shown the same type of effect, because in those in that area, it is 60 to 79% aged group having this comorbid condition, and number of medications within these groups are found to be 8 to 9 medications per individual. Another study that was conducted in Canada and Canadian Institute of Health Information, they have also shown the incidence of polypharmacy in Canadian senior citizens, where they have shown that 25% of the senior citizens over 65, they're using 10 medications, and when it is it is almost 40% increased among the age of 85 years old age patients. And so seeing all these examples, we can easily understand that our elderly populations are overburdened with this medication. And therefore, seeing all these examples and the research work, our group have decided to go through to conduct a literature review, and we have decided to evaluate the impact of the polypharmacy in geriatric population in COVID-19 condition. And in this literature review, what we have found so far, that that it has, due to the increase of the life expectancy in the population, elderly population, which is associated with multiple morbidity, and which is also connected to polypharmacy. And the problem of polypharmacy is likely to become worse. And it is found that this elderly population has increased risk due to their comorbid condition, and specifically that is seen in this COVID pandemic condition. And fatality is much more higher among the 60 to 80 years of age, and majority of the COVID-19 patients, we have found that they are, when they are affected with pneumonia, and they had to admitted into the ICU treatment. And among them, the geriatric population's prevalence is higher, and that is, and they are affected with multiple comorbid conditions. And this is, although this is a data for a Chinese study, but we have also identified that the globally, that 3.4% of the reported COVID-19 cases have died, and the more prevalent among them were the elderly population. And when we compared it with the polypharmacy condition, it is seen that the cause of death among this group is related to their low immunity, geriatric syndromes, medications, non-adherence, and that is associated with their comorbid condition. And in addition to that one, it is found that the increased risk of adverse event due to reduced functional capacities are also demonstrated among this geriatric population. And this risk is furthermore worsened when there is increased number of medication that has been applied to the patients of elderly COVID patients in their treatment procedures. And so this chart deliver the harmful effect of the polypharmacy in the geriatric population. And it is most importantly indicating the use of inappropriate
Dear Dr.
polypharmacy.
Saida, you have 2 minutes
Yeah?
more. You have
All
2
right.
minutes
Okay.
more.
Thank you. Thank you. Thanks for reminding. And inappropriate polypharmacy, and which has a significant negative effect on person's health, and it is also associated with the increased risk of adverse effect and adverse drug reaction and drug reactions with the disease state also. And the adverse effect is also associated with the mortality, hospitalization, drug-drug interaction, and drug disease interactions during this COVID condition. The drug-drug interaction is also very serious among these COVID patients during the time of the treatment. So whether we need this polypharmacy then, because the polypharmacy is very much important for a biggest challenge actually for the general practice. And according to WHO, which shows that in some cases the polypharmacy is required and sometimes it is very advantageous. So we have to prepare something and we have to go through an appropriate polypharmacy to trigger an evidence-based treatment approach for the specific group of population in the case of COVID condition. And if we now conclude our what we have found in our research systemic review, that COVID patients that are the aged one who have they have polymorbidity and polypharmacy, and they have and the polypharmacy is one of the significant challenge for the practitioners or the physicians to treat this elderly patient when they are admitted to the hospital. And therefore, we also recommend to what we have found. On the basis of that, we could recommend that if we do some, if we do practice on the basis of the evidence-based treatment approach to the patients, and we the dispense and the irrational medication are strictly avoided. And that will help us a lot to prevent this adverse drug effect, drug-drug interaction, and all these things. And in addition to that, we can provide training to the healthcare professionals and caregiver to this elderly population. And so also take the guidelines from WHO, CDC, or any international guideline that can help us to overcome this condition. So that is all. And basically, this global pandemic has given us the lesson to renovate the total healthcare process, and that can improve our loving planet. So thank you very much, and thanks for listening. These are the list of my references, and I also thank chairperson and the participants and others to give me the opportunity to talk about this thing in this conference. And Public Health Foundation, thank you, thanks a lot for
Dr.
this
Saida. Brilliant, brilliant. Okay, you have actually controlled your time anyway. Now I would like to actually invite the rest speaker for this session, for this slot. So who is going to actually present this one? I have no idea. Please come up. May I request? Yeah.
Tanvir Chaudhary Turin.
Okay, please. Go ahead, please.
Okay, thank you. So I just am trying to put my slides on, and then hopefully, can you guys see the slides? If anybody can give a nod, that will be great.
Yes, we can see it.
Yes,
Is this part of the slide?
Yes, it's a part of the slide.
Okay,
so,
okay. You can explain this one. You can explain this one.
I think I just wanted to highlight a couple of points during our previous session and current session. The audience have been talking, especially like Professor Mahmood Rahman was talking about. It's important to capture who has done what and bring them together. There is an intra-action review, just sharing the research and bringing the research to the platform, and decision that will aid the decision to be made in future. Professor Ahmed had also made an important point, like policymakers' involvement to overcome the issues around the problem is hugely important. important. Dr. Aftab also made some points during the previous session. I'm not sure if he will have time to make a comment in this session. So, and Public Health Foundation is arranging this, how to call it, this conference that is being a platform to share information regarding a health issue that we are facing. So based on, I will come back to this point again. And just a quiz, like anybody, any idea who this guy is? Usually I give 30 seconds, but I will skip that. So this guy is Mr. Vasco da Gama. So the idea behind this guy's story is, we all know that he was one of the people during whose voyages we came to know about the scurvy disease. And somehow during his voyages, few people of his team took the lemon during the long voyages. And then that seemed to be improving, like there was, that has a positive effect on scurvy. So the main point here is like, it was in 1497, the knowledge came up, like the scurvy is helped by taking lemon. But in 1865, it was, like a mandatory for everybody in the sea voyages to take lemons. So there was a knowledge to action, but unfortunately the knowledge to action that took 368 years to execute. So that's point number one. And do you guys know what is the condition nowadays? The condition nowadays is like 365 years becomes 17 years on an average now. That means during nowadays, 17 years is needed to translate an evidence from discovery to practice. But on the other hand, only 14% of what we discover is going into clinical practice. Despite, what we discover is positive things, but despite that. So there is a big mismatch due from knowledge to action. And then, that happens like, 30, we know that 30 and 40% of the patient do not get treatments of proven effectiveness. 20-25% of the patients get scared, probably due to, injection by the lobby group, the pharmaceuticals or intervention instrument creation groups. They push on things that are not needed per se. So the main point here is there is a difference, there is a mismatch. Now, this mismatch has generated interest so that we can create now evidence to practice how this gap can be reduced type of research that we sometimes call implementation research or other type of research. Now, today, I'm going to present the concept that we are working on, the knowledge engagement. It's more of a connecting the academia, the practitioners, the policymakers, and communities for the impactful action that can be taken on the grassroots. Though I am from University of Calgary in Canada, I am representing today the International Health and Wellness Research Network Bangladesh, focusing on Bangladesh, and with the extended team members that we have started the baby step of the thinking about it. So we are thinking about, hey, what about a knowledge engagement hub? So let me talk about what is knowledge engagement. So knowledge engagement is a mixture of any activity that makes sure knowledge is generated and it's taken to the people. So it's more of a knowledge creation. That's the research, knowledge mobilization, that's applying the research, and knowledge exchange so that we can come up with the research ideas that is meaningful to the community. It's not me in the 7th floor in a glass window in a cubicle, I'm coming up with the research ideas. So again, this is surrounded around the beneficiaries, our grassroots people, and I can wear different hats in different times. So again, it's about bringing the policy, teaching, service, and research together. Without bringing them together, we are not going forward. So a couple of things that I want to point out, community engagement. So what is community engagement? So it is a dynamic relational process that facilitates communication, interaction, involvement, and exchange between organization and the community. The community that we are working or we are striving to improve the condition of. Implementation research. What is implementation research? It is an integrated concept that links research and practice to accelerate the development and delivery of public health approaches. The third thing that I want to bring in, the IKT, we call it like integrated knowledge translation. What is? It's about engaging the knowledge users in every step of the research we do. So if we bring them together, so knowledge engagement in another angle looks at that. So we are looking at knowledge engagement in two angles. One angle ensuring all the domains are getting together, another angle ensuring all these type of community engaged methodologies are applied to do the work. So based on that, this knowledge engagement hub, Bangladesh Knowledge Engagement Hub, or focusing on a conundrum, will be making sure these things happen. So we are trying to propose and facilitate a community-based knowledge mobilization lab or a hub. Think it's a garden. It's a garden for facilitating research, facilitating partnership. And within the garden, me, Turin, as a researcher, can plant few trees. These are my research topics, and I planted it. And probably I reached out to Professor Aftar Ahmed. Hey, would you like to nurture these projects with me? So we are trying to get all of those together. And there can be other people coming up with, trees of their own, and that can be co-nurtured based on the interest. If somebody wants to do some cardiovascular epidemiology thing, I will be happy to co-nurture. But if somebody is doing mental health, probably we will find somebody else who has more interest and, expertise to co-nurture. But our focus is to make the garden first. So again, as I said, it's more of a through our network that we are, a baby step we are trying to do, because there has been lots of breakthroughs, about research, and we researchers are good in making breakthroughs, but we are not that good in making follow-throughs, and we cannot alone make follow-throughs. We need the system to work with us, or system also facilitate our work so that we can make the follow-through. And then, there are billions and billions in investment on biomedical and health research, but lots of things doesn't get implemented. As I say, only 14% goes in that. So we need to improve that condition. That's another angle of research, and philosophical research, epistemology of research. So we have just taken the baby step. And for, from our team, one of the leads that out in Bangladesh is like, if anybody is interested, maybe getting in touch with him to see how we can, take the baby steps together. And, I will just cut it short and thank you for everything. So these are a couple of monkeys I have. So just wanted to share this with you guys. And I rest my case then. Thank you.
Okay, so excellent, Tanveer Turin Chaudhary. And anyway, so may I ask the panelists for very brief and to the point comments? Very little time I have. So who is going to volunteer? I don't know. Please, floor is open. Yeah.
Wonderful presentations from all the presenters, Farhana, Yasmin, and Dr. Saida and Turin. Nice research projects, and we are enlightened with your thoughts and projects going on, and wish you all the best. I don't have any question. I just am expressing my gratitude to the panelists and the organization committee, and as well you, sir, Professor Aftab Din. So thank you very much. Have a good day.
Okay, so is there anyone who would like to? Yeah, Tawfiq.
Hello.
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 That's great. So
yeah,
can you make very brief comments? Because I don't know you had the opportunity to follow all the.
No. I actually had only the opportunity to hear the presentation by Dr. Tanveer Turin Chaudhary.
Okay. So and, please make a very
the
very
tail
short
ending of that. So
please.
Actually not in a position to comment.
Okay, please.
Just wanted to apologize for being late. Basically, I was stuck in the terrible Dhaka jam, and which is also indicates kind of a systematic failure or systems failure, and
yes,
very much connected to each other. So
please,
yeah, thank you very much for your presentations. Although I didn't have a chance to look at it, but I believe I can actually go through some of the presentations, your slides. So I actually wanted to highlight one important issue that that when we talk about health systems, we have some preconceived ideas about health systems. Some of us think that it's just about management. Some of us think that it's just about managing the hospitals or running the hospitals. But we often forget that health system is actually all the actions and all the institutions and the persons who actually join together to come together to perform some tasks whose primary intention is to promote, restore, or maintain health. And the interconnected nature of the health system is often ignored in our collective psyche. So when it came to the COVID-19 situation too, different people came up with different ideas. And this conversation was there, and this conversation is going to be more important or more pertinent in the coming days when the vaccines will be available. So as long as we cannot really address the collective nature of the health systems and address the connectivities of different parts, different moving parts of the health system, it will be very difficult to really address the issue of the COVID-19 as well. For example, when the vaccines become available, we may think that it's very easy to actually get the vaccines to the people, but it may not be, because if you engage, for example, your human resources for health, your health workers, maybe 2, 3, or 4 health workers in a health center, for example, in an Upazila health complex, but if you don't anticipate the patient load and the load of the people who will be coming to actually take those vaccines, there will be the problem of crowding out. We know what is crowding out. For example, the people who are already there to take care, the quality of care for those ailing patients will be compromised as long as we don't have something planned to address the crowding out issue. For example, secondly, it's possible that when we think about the vaccination, we think about the childhood immunization, which Bangladesh is actually very good at. But when it comes to COVID-19, it will be an issue of adult vaccination. So when we think about all these things, these are all moving parts, and we need to actually combine all our efforts from different angles. The discussion of health system is fascinating. At the same time, is very complex, because you cannot just think about one aspect of the health system and think that your job is done. It's very much interconnected. You move one part, it will affect the other parts in a simultaneous way. So it's very complex, and a continuous discussion should go on. So I want to thank all of the presenters, although I haven't had an opportunity to all of you, and want to emphasize this this collective nature of the health system issues, and request you to put your heads together and keep this conversation going on to solve the global crisis, because global crises also have bearing on the local crisis, and the vice versa. So let's put our heads together. Let's think about health systems in a dynamic way rather than in a static way. And that's actually the way you deal with the crisis of the health systems, and get prepared for the next one that may be lurking around the corner. Thank you very much.
Thank you, Dr. Tawfiq.
Thank you very much, Tawfiq Jordan. It was really useful. At last you could come and join. And anyway, I would like to just finish from my side within 1 minute. One important issue that you, Dr. Tawfiq, put together, it's about the systems thinking, that which is a wonderful issue for the 21st century. Back in 2009, since then, systems thinking is actually a pervasive one. So without this sufficient or adequate knowledge and attitude towards that, we cannot make any dent in the health system, as Dr. Tawfiq mentioned about this one. So we will be always truncated in just box by box, but we need to have an integrated approach for all this. Anyway, the other thing that Dr. Tanvir Turin it's a very favorite area for me. The implementation research. Anyway, I used to teach the implementation research in JPG School of Public Health for the TDR fellows, WHO TDR fellows. Anyway, this is something that how to translate the research into action. Anyway, it requires 17, 18, 15 years anyway. So all the 4 papers, I would say that very brilliant, excellent delivery, and very important and timely. But there are, of course, the quality issues are there. There are more of learning things are there. There are so many lacunae that there. We need to actually acknowledge this one for our learning purpose, further learning purpose. So I would request all the presenters that you did excellent job, but at the same time, you need to actually look back into this, the nitty-gritty of the different areas of the study. So one by one, we have not much time to actually dissect everything. And okay, next time if we can put together. But at the end, I would like to finish by saying that we have here together a very rich wisdom together. So if you consider the knowledge, the wisdom and other things, the experiences, I don't know about the professional experience altogether, cumulatively, huge. So as Taufik pointed out, cross-learning is important. Cross-fertilization of ideas is important. So how do we achieve this? Is achieved if we develop the culture of cross-learning. So that's all. Thank you so much. I really enjoyed. So Taufik, if you would like to, but I have to leave now. So thank you. Excuse me.
No, thank you.
I would love to continue, but anyway, I have another.
No, actually, we are already over our assigned time, so
thank you.
No more.
Thank you.
Taufik sir. Taufik sir,
yes.
Dr. Sayeda had a question. Pradeep Gupta had a question to Dr. Sayeda.
I mean, yeah, I mean, I don't know, Dr. Aftab, do you want to allow some? Could you? I mean, you are muted. Can you turn on your microphone, please?
What's the question? Do you have any data that prove your hypothesis that polypharmacy increased the rate of morbidity and mortality among senior citizens during COVID-19 pandemic than pre-COVID time? That goes to actually Saida Rahman. But
okay,
anyway,
yeah.
that was also a very interesting and very important topic for today, polypharmacy. Polypharmacy, not always bad, but polypharmacy, not only for the COVID season or pandemic. Before that, it is as a time for a long time.
Yeah. So actually, we have not collected any data, but we have. Can you hear me?
Plus all.
Can you hear me?
Yeah, I can. We can hear you actually.
So basically, we have done a literature review. So we have not conducted any data collection for that. And on the basis of the literature review, we have collected the information from individual studies and articles that have been conducted on polypharmacy and the effect of lots of medication and comorbid conditions that had affected the COVID patients, and specifically the geriatric patients that have come out through different literatures. So we have not collected on the basis of that any specific data for data-wise that numerical type of information from those articles.
Yeah, my point is there before I leave, because I have another favorite subject here, favorite topic here, polypharmacy. I think we have no sufficient or adequate any connection with that polypharmacy actually really caused the increased morbidity with the senior group. But yes, there might be, because I don't know if there is any sufficient data about this one. Polypharmacy.
No, not sufficient data. I would like to add it here something, because when the chloroquine or hydrochloroquine is added to the patients at the beginning of the COVID treatment process, and it is seen that the geriatric population, they're having a lot of cardiovascular effects due to the different other medications they're using, and they're having drug interactions with those drug interactions. So on the basis of that, they were showing it.
Okay, Saida. So that's opened up another Pandora box. That's did you do this systematic review on this? Do you have?
Yeah, we have done only the literature review. Yeah.
Literature review. So the topic is there. I have not sufficient time. We need systematic review.
Yeah, we need a systematic review.
Otherwise, we cannot actually can be sure that this is linked up. Okay. Anyway.
Yeah. We have done only the literature.
Thank you. Please bear with me. I have to leave now.
No, thank you, sir. Thank you.
Okay, thank you very much. Thanks a lot.
Thank you all.
Thanks a lot.
Okay. Yes. So do you have any further questions? Any more questions? So I just wanted to add with Dr. Aftabuddin that, I mean, systematic reviews may, I mean, even if you don't have the primary data on polypharmacy, but a systematic review could actually go a long way. But still, since you have done literature review, which is also a good source of knowledge, obviously. So thank you very much for your answer. Is there any other question, Rabbani?
Sir, we have no more question from audience or any other panel member.
So, I mean, if there is no other question or anything else that you want to add, I mean, I like to add, I like to ask the panelists if there is anything else that you want to add. Otherwise, we can actually close it. I mean, close the session, call it a day. Yeah. Anything else, Dr. Tanveer, Sayeda, Dr. Aisha, Dr. Farhana?
Oh, nothing else, but just a big thanks for Public Health Foundations for the opportunity to present.
Thank you very much, actually. Yeah, thank you very much for being present. And again, apologies for not making it on time. It was a different story.
I would also like to thank Public Health Foundation, because it is quite well organized. I found it, because time to time I got the message every day in my email that when the session is going to be started. And thanks to Mr. Rabbani, because he replied to my email very promptly within few minutes of time for any queries or questions asked regarding the conference. Thanks a lot, Mr. Rabbani.
Very prompt, and we are very lucky to have Mr. Rabbani with us. He is actually the program coordinator for the whole conference and also moderating this session. So a big hands to Mr. Ghulam Rabbani. And with this positive, yes,
everyone. Please. Sorry to cut you off, but I would echo everyone's sentiments and thank you for the opportunity to present. And I actually didn't know of the Public Health Foundation. I learned of it recently, and I think you're doing a lot of important work. I'm a clinical cardiologist with an interest in clinical trials. So I'm actually looking for like-minded people in the country to work on meaningful projects. So congratulations on everything, and thank you so much for the opportunity.
Thank you very much. So we basically look forward to your participation and contribution to the organization in future endeavors. Absolutely. So thank you very much. And with this positive note, I want to thank again and close this session for tonight. And hopefully you will attend our other sessions tomorrow and also the closing ceremony tomorrow. So thank you very much.
Okay, thanks a lot. Yeah. Goodbye.
Goodbye.
Goodbye. Thank you, everybody.
Bye. Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.